Dr. Elizabeth, after you introduce Dr. Shabana, maybe she should start straight away, right? I will just introduce the session as a whole. So Shabana, you will start talking after Dr. Elizabeth introduces you. Okay, is that fine?
That sounds good, yes.
That's good. And then once your talk is over, I will moderate the Q&A. That's what I planned.
That'll be good, yeah. Perfect, yeah.
All right.
So the session is live, you can start.
Okay. So good evening, friends. I want to welcome you all to the international webinar this evening hosted by the Believers Church Medical College Hospital here. And I want to welcome all of you who have joined in. And we are set up for a good session today, very educative one on how do you evaluate short stature, children with short stature. And we are privileged to have Dr. Shabana Kaladi with us. On the, I think this is the second time. Am I correct, Shabana? You're with
That's
us?
right. Yeah.
That's
Yeah.
right. And so she's kindly woken up early this morning to give us the talk in Michigan, right? Cold there. And I really hope that we will all have a very good time. And please, may I request the participants to kindly mute your microphones, otherwise it can be disrupted. And I would encourage you all to write down your questions which pop up in the chat box, which I will be monitoring, and maybe at the end of the session, I'll take questions. So once again, I want to welcome everybody who's here. I also want to invite my co-chair, Dr. Elizabeth Cherin, who's a senior consultant in pediatrics here in Believers Church, to kindly say a few words and introduce the speaker, after which Shabana would be speaking to us. So over to you, Dr. Elizabeth, to kindly say a few words and introduce Madam.
Thank you, Dr. Philip. Now I'll be happy to introduce Dr. Shabana. She's a practicing pediatric endocrinologist in Michigan. She holds a clinical faculty position as assistant professor in the Department of Pediatrics, Oakland University, William Beaumont School of Medicine. She is an American board certified in both pediatrics and in pediatric endocrinology and metabolism. After medical school in India, she completed her residency in pediatrics at St. John's Providence Children's Hospital, followed by a fellowship in pediatric endocrinology at Virginia Commonwealth University, where she developed a keen interest in pediatric thyroid cancers. She is an ardent advocate for children with type 1 diabetes and serves on a voluntary basis at the annual diabetes summer camps conducted by the American Diabetic Association. She is a reviewer for the journal Clinical Pediatrics and is consistently recognized by her peers as one of the top docs in the Our Detroit magazine in her field. Primarily a clinician, she is a co-principal investigator of the ongoing pediatric drug trial for the treatment of type 2 diabetes in children. She is a regular presenter at the Endocrine Society meetings. Her special interests include pediatric thyroid cancer, pubertal disorders, and monogenic forms of diabetes. Over to you, Dr. Shabana.
Thank you, Dr. Elizabeth. I'm just going to share my screen here. Good morning, everyone, or should I say good evening. Happy to be here again. Today, I was hoping to talk about evaluation of the short child with a little bit of focus on growth hormone deficiency at the end. Actually, without further ado, I'm just going to skip right ahead. Okay, so the objectives of my talk, I'll start with that. The first is to develop an understanding of normal growth in children, infants, children, and adolescents. Understand some current methods we have for measuring children, describe some conditions that lead to variations in human growth, and then approach to evaluation of the short child, right? And I'll go through these objectives one by one. So a couple of overview points. So growth in children, a careful assessment of growth is a sensitive indicator of health and well-being. Deviation from the normal pattern of growth with an acceleration or deceleration in growth requires a very timely planned investigation. Focus on the word timely. Okay, some of the key contributors to growth are, of course, a supply of nutrients, which is the main factor regulating growth, The genetic background of a child provides a general framework for growth. Hormones regulate growth processes, which are contained in the genetic code, and environmental factors influence the expression. Growth patterns, and the pediatricians in the audience, I'm sure, will be familiar with a lot of this, but I'm going through some of these basics as we do have some medical students as well in the audience. So growth is not uniform. It consists of periods of starts and stops. This little staircase is meant to indicate that it's not always uniform. We do see something called compensatory or catch-up growth, usually seen after a period of illness, starvation, intrauterine growth retardation. There's also a consideration for psychosocial dwarfism, where children who are raised in a poor psychosocial environment, when they are then later moved into a more thriving environment, they have catch-up growth as well. Okay, so moving on, normal growth pattern is a sign of good health. Deviation from the normal pattern of growth may be the first sign of a disease process. And this is a luxury we have in pediatrics, I say, because in adults, the growth is complete. Whereas in children, when you have a deviation from the normal pattern of growth, it may be the first sign of a disease process. Of course, infants, children, and adolescents have their weight and height measured and properly recorded at every well visit. Sorry, I thought there was an interruption, but moving on, accurate measuring is essential to permit correct interpretation of the growth curve. Okay, accurate measuring, I've highlighted that because I cannot stress the importance of that enough, and I'll go over that as well in a few slides going forward. All right, so moving on to phases of growth. This is broadly divided into three. So the first would be infant growth, which is usually roughly from birth to 2 years of age. This is postnatal growth and is dependent on nutrition, thyroid hormone, and growth hormone. Children often will cross percentiles, moving towards their genetic potential after 6 months. And I'll highlight some of these again in my future slides. The next phase is what we call childhood growth, typically from 3 years until puberty. And we expect that children should remain in their growth channels quite religiously after age 3 years of age. The next phase is what we call adolescent growth, where pubertal growth, essentially the pubertal growth spurt, contributes to about 15% of the final adult height. And this is the second period of growth where growth percentiles are crossed. The first would be in that infant growth stage. Okay, so what I want you to take away from this would be that children should remain in their growth channels after 3 years of age. All right, so this table is kind of a nice way of looking at growth velocity. After birth, the growth rate is simultaneously the most rapid and the most rapidly slowing of a child's growth experience. So if you look, from 0 to 6 months and 7 to 12 months, they're growing rapidly, 1.2 centimeters a month, 2.5 centimeters a month before that. And then moving down as they hit, age 5 onwards, they're down to 5 centimeters a year, 5 to 6 centimeters a year. So we want to be familiar with expected rates of growth at different phases in a child's growth. Right, a few points on basic data. Average birth weight is 3.5 kgs. This is in the United States. In India, and it's, as far as I remember, it was lower, 2.5 or 2.75 average birth weight, length of 51, fronto-occipital circumference of 35 centimeters. Some reference data is useful, so I'm just putting these in to be complete. Typically, newborns will lose up about 10% of weight after birth. They should regain it by 2 weeks, gain about 30 grams daily. Infants later will gain about 20 grams daily. You expect the birth weight to double by 4 to 5 months and triple by about 1 year. And the head circumference also increases. There's a rule of 3s and 9s, increases by 5 centimeters at 3 months, 9 months, 3 years, and then 9 years as well. A quick word on the pubertal growth spurt. This is a chart that some of you may be familiar with, the height velocity chart. The reason I included this is because pubertal growth plays a key role in determining the final adult height outcome. The female pubertal growth spurt is actually earlier. So this is the female The dotted line indicates the female pubertal growth spurt. The velocity is the rapid growth velocity that we see in puberty occurs a little bit earlier in females, a little bit later in males. The amplitude is also low, as you can see. And this difference in amplitude is actually responsible for the 13 centimeter or 5-inch difference that we see in heights between men and women. Okay, so measuring growth accurately. Appropriate devices for measuring infants and children are essential. These seem, sort of, the next few slides, I'm going to actually focus on that because however trivial this seems, I think all pediatricians will agree, this is critical. Accurate measurements, you cannot really go back and measure back in time. You need to have a good measurement at the time that you're assessing the child and going forward. So in our clinic, we use a measure twice, plot once policy. All children are measured twice. Heights, actually, we measure 3 times, and we make sure that the difference is less than 0.5 centimeters between measurements. It's important that the child is measured with all these points noted. The shoes need to be off, heels together, head, shoulders, buttocks, and heels in contact with the vertical surface. We want hat and hair ornaments removed. This is really important. And you want to measure with ensuring that the Frankfurt plane, it's the line between the outer canthus of the eye and the tragus is in a straight line. Right? This is an example of how not to measure. Essentially, he's got his hands in his pockets. We're using a flexible head. The head, this little head stadiometer is flexible. We don't really want to use that. Measurement, ensure that the diaper is dry. It can add quite a bit to the weight. And then when you compare, it looks like a false increase or decrease in weight. This is just a picture of the stadiometer that we use in our clinic. It's simple, doesn't need to be complicated. All right, so now that we've kind of gone over a brief overview of growth, normal growth measurements, I'd like to spend a few minutes on growth curves and growth charts. This is a little theoretical, but I think it's useful to know the history of growth charts and why we use the ones that we do. So growth curves, what are growth curves? And again, pediatricians will be very, very familiar with these, but I'm going to just go over what growth curves we use in the US and why. Okay, so they are a series of percentile curves that illustrate the distribution of selected body measurements in children. So this could be height, weight, head circumference. In 1977, the growth charts were developed by the NCHS, or the National Center for Health Statistics, as a clinical tool to determine if the growth of a child is adequate. In 2000, the CDC made revised growth charts, which were basically a revised version of the 1977 NCHS growth charts. So what do we use currently in the US? So the CDC recommends that from age 0 to 2 years, we use the WHO growth charts to monitor growth. And then for ages 2 years and older, we use the CDC growth charts. The reason that we use the WHO growth charts for children ages 0 to 2 years of age is because the WHO studies were a higher quality study. They were longitudinal. They were based off of children who were breastfed at least until 12 months of age. So they were a better reflection of how children should grow. Whereas the CDC, we didn't really have very great data until age 4 to 6 months. And these were not longitudinal studies. They just showed us how children were growing, not necessarily how they should grow. So currently what we use are the WHO charts 0 to 2 and CDC for 2 years and older. This is an example of that chart. This is the 0 to 2 WHO standard, and this is the 2 to 20 stature for age and weight for age percentile standards by the CDC recommendation. All right, so coming to the what we call the meat and potatoes of the talk, what do we need to consider when evaluating growth in a child? Right, so the key questions, I will list these and I'll try to go over each of them and maybe work through a case at the end of it, applying what we went through. Okay, so let's see. First question is the child short? Okay, that is the first thing to answer. Is there actual short stature or not? Next one would be, is the height velocity impaired, rather the rate of growth? Is that impaired? The third question would be, what is the mid-parental height? We'll go over that in a second. And lastly, what is the predicted adult height? Okay, so I will move through each of these questions. So the first one, you've got a child, is the child short, right? Is there true short stature? So by definition, short stature is a length or height that is more than 2 standard deviations below the mean. Usually this corresponds to a height that is less than the 2.3rd percentile, so well below the growth curve. Okay, so next question is the height velocity impaired? Now this is, I would argue, the most critical aspect here. So height velocity, we would consider even a vital sign in pediatrics. It is measured in centimeters per year. The interval between measurements, you want it to be at least 6 months. And for children who are 2 years and older, growth failure is very likely if your height for age curve, meaning the height curve, has deviated downwards across 2 major percentiles. So for example, if they were at the 75th, they are now down to the 25th, right? They've crossed 2 major percentiles. Or if the child is growing slower than 5 centimeters per year, which is the normal prepubertal growth rate. Okay, so these are very critical points to consider when evaluating a child: height, velocity. The next step, what is the mid-parental target height? So this is something that is calculated based off of the mother's and father's height. So the calculation is essentially, if it's a girl, you take mom's height, dad's height, take away 13 centimeters and find the average of that, and that is the mid-parental target height. For a boy, it would be mom's height and dad's height, add 13 centimeters or 5 inches, and average of that would be the mid-parental height. Yes, and normal range is usually within about 10 centimeters of that mid-parental target height. So if we calculate a boy's mid-parental height to be 5'7", then your normal range of expected final height would be within 3 inches of that 5'7". So anywhere from 5'4" to 5'10". And we really make it a point to tell families, this is the expectation. It doesn't mean he's going to be 5'7". If he's 5'4", that is considered normal, because that is the genetic sort of potential based on mom and dad's height. Okay, so prediction of adult height. This is a very common consult in my clinic, as you can expect. How tall is my kid going to be? This is a burning question for many parents, predominantly boys, not so commonly in girls. Boys are typically the ones that we see for short stature, because the concern is sort of skewed towards that. All right, so there's no very straightforward answer to that, but it is a combination of genetic potential, like the target height or mid-parental target height that we just discussed, and many other factors. We usually will discuss with families that there's really no method that accurately predicts the adult height. It is estimated, it's only an estimate, using the mid-parental target height based on mom and dad's height, the projected height off of the growth curve, and what we call a bone age X-ray. Okay, and that'll be my next review. So what is a bone age X-ray? Pediatricians and endocrinologists would be familiar with this. I am curious to see what we use in India for bone age X-rays, what atlas or what references are used. We typically use the Grellich and Pyle atlas. So what is a bone age X-ray? It's an X-ray of the left hand. It uses the skeleton to assess the biological age of the child. The X-ray of the left hand is compared to an atlas of standard hand X-rays. This is what I was talking about, the Grellich and Pyle atlas. And the prediction of final adult height is done using a Bailey-Pinot table. That is actually a part of the atlas. So this is a very useful tool in our initial assessment of a child. We get a bone age X-ray of the left hand. Okay, so this, for example, the one I have here is a bone age X-ray of a female. The bone age is 7 years and 10 months. Doesn't mean that the child is 7 years and 10 months. If she is if she may be 10 years old, she may be 6 years old. The bone age can be different. It gives us an assessment of skeletal maturity. All right, moving on. All right, so we've covered overall growth patterns. We've kind of covered what are the key questions to consider when we are evaluating a child. Now we come to the next step, which is what are the indications to evaluate growth? So we've got all these data points, but when should you actually evaluate growth, right? So I'll go over these one by one. So the first thing would be a prepubertal child with a growth velocity that is less than 5 centimeters per year. 5 centimeters per year is the lower end of the cutoff. A prepubertal child should be growing 5 to 6 centimeters per year. And that is why even more important to get accurate height measurements. All right, the other indication would be if the child is less than the 3rd percentile, so more than 2 standard deviations below the mean for age and sex in the local population. Another indication would be if the growth trajectory differs significantly from the family tendency. So, and I'll have an example of that in a second. But essentially, if your family is tall, dad is more than 6 feet, mom is 5'10", 5'11", and the child is kind of growing along a very low percentile of the growth curve, that may be a reason to consider evaluation of growth. Not necessarily it's pathologic, but you may want to consider. Another reason would be abnormal body proportions. I have a slide in a second to talk about proportions. And lastly, if the child is crossing downwardly more than 2 major percentiles, say from 90th down to the 50th prepubertal, then we want to consider if there's something that's affecting that growth. Right, so quick word on body proportions, because I mentioned that abnormal body proportions would be an indication for growth. So proportionate versus disproportionate. Proportionate short stature is, as the name implies, a proportionate shorting of both the axial and the appendicular skeleton. So the axial skeleton is short, as is the appendicular skeleton, which are the limbs, versus disproportionate short stature. Some of you may recognize this guy. He has achondroplasia, and what we see is disproportionate short stature, meaning the trunk or the axial skeleton is relatively preserved, whereas the appendicular skeleton is shortened. So that's what we call disproportionate. All right, so this is a slide that actually I've tried to put together all the possible causes of short stature. It's a broad differential diagnosis. The first step, of course, is to pick up if the child is truly short, right? Now, once you've got short stature, the question is this a pathology or is this just a normal variant, right? So if you have common causes, mainly familial short stature, I'll go through a couple of these. We have idiopathic short stature, meaning they're short with no obvious reason or pathology identified. Maybe they were born small for gestational age without catch-up growth by age 2 years. You can have endocrine abnormalities. I'll briefly touch on endocrine abnormalities as we are in endocrinology, and I will, each of these could be a talk in itself, but I'll do an overview. It could be that the child has a metabolic disease. Short stature could certainly be a presenting symptom. Chronic illness, GI illness, it could be pulmonary disease like asthma, cystic fibrosis, cardiac disease, renal disease, glucocorticoid treatment, chronic therapy with steroids could cause growth delay and stunting. Skeletal dysplasia, of course, usually those are more disproportionate, as we just spoke. You could have psychosocial dwarfism. Some of these children could be just part of short stature could be a feature of a syndrome such as Turner's syndrome or Noonan syndrome or trisomy 21, Russell-Silver syndrome, Prader-Willi or DeGeorge. So broad differential diagnosis. Our goal is to identify, is this child likely just a normal variant or is there a pathology going on, right? So the what we call normal variants would be familial short stature and constitutional delay of growth in puberty. So I will try to go over these two in the next couple of slides, that if we are comfortable identifying what is likely to be familial short stature or constitutional delay of growth, we don't really have to do unnecessary workups, right? And of course, I'll talk about some of the endocrine abnormalities briefly and what kind of growth curve you would see if this is truly an endocrine cause of short stature. All right. Any burning questions at the moment or anything in the chat? I'm just going to check. Don't see anything. So I'll move on. All right, so these are the normal variants of growth, as we just said. There's familial short stature and there's constitutional delay of growth in puberty. Let's move on to the first one, which is familial short stature. What is familial short stature? So it is really a short, healthy child. It is a diagnosis of exclusion. As the name implies, the family is of short stature, the mom and the dad. And so the child would be expected to be within that range. The bone age, if you did a bone age X-ray in a child who has familial short stature, it would be consistent with the chronologic age. So for example, you have Johnny coming in for a checkup, and his mid-parental height, I don't know if you can see my arrow here, his mid-parental target height is, say, the 5th percentile. Say mom and dad are 5'4" and 5'1" and 5'6", the target height would be pretty low. If you get, and then if the parents are concerned about short stature, you get a bone age, it would be the same as his actual age. So if he's 8, his bone age would be expected to be around 8, not delayed or not advanced, right? They typically have a normal growth velocity. If you recall how critical growth velocity is in these assessments, you do want to have a normal growth velocity in order to say that there is no pathology. And if we end up testing them, we have tested some of these kids for growth hormone deficiency when there's severe short stature in the family, and typically they are not growth hormone deficient, of course. All right, I'm just going to see if there's a question on the chat. Oh, I think Dr. Philip is suggesting put some questions in the chat if you have any. Just close this. All right, so moving on to from familial short stature to the next, which is constitutional delay of growth and puberty. This is another very common consult that we have in our clinics, where a parent brings in, Timmy, saying he's smaller than all the kids in his class. What is is something wrong? All his peers are bigger than him, and he is feeling very self-conscious. Is there anything wrong, or should we do anything, right? Now, constitutional delay of growth and puberty, if you look at his growth chart, typically when they come in to see the endocrinologist is right about when they are falling off the growth curve. And it can look quite drastic and quite concerning, because they are well below the curve. They are truly short, right? So they do warrant an evaluation, at least. The critical point here is, again, normal childhood growth velocity. So the velocity does not change. It would be in the prepubertal range. It would look like it's slow, because most kids around age 12 or 13 are starting to pick up on their velocity, whereas these kids are still prepubertal, so they're growing at 5 to 6 centimeters a year. Okay, now in these, this is where the bone age plays a big role. If you get a bone age X-ray on a child that is a late bloomer, right? That's the term that's used. They mature later. They are late bloomers. They would have a bone age expected to be delayed. So, for example, if Timmy is 12, his bones may only show 10, right? And that way, when you predict the height, it's going to look better. Some of these kids will have a prepubertal slowdown of the velocity, which even further exaggerates that difference. So this does cause a lot of stress with families. It can be quite distressing for children, especially when they're in sports and all of their peers are much bigger than them, almost close to adult height. So very common consult in our clinics. A family history is very useful. Oftentimes dad will say, yes, I grew late in my, I grew after all my friends, and that's a very useful piece of history. Or mom may mention that she had a late period. That's again very useful. Again, so this is the diagnosis of exclusion. And most of these kids will achieve familial target height. They have to kind of wait it out. After all their friends have had their growth spurt, they have their big growth spurt. And finally, they usually will achieve final adult height that is appropriate for the family. Okay, moving on. Okay, so those were the two main normal variants of growth. So familial short stature and constitutional delay of growth in puberty, bone age and height velocity are very important features that help us distinguish between the two. Now, I will just briefly go over endocrine disorders that affect growth. So this is an endocrinology lecture. I will briefly touch on these. Let me just check the chat here. The question is, do we use growth charts or have we switched to software? We use a software in our electronic medical records. It's nice because we plug in, mid-parental, we plug in mom and dad's height. It calculates the mid-parental height for us. It also pulls in height data from outside institutions and puts it all together on one chart, because sometimes all, the whole workup could be different based on one good height measurement, right? So it's made life much easier now that we can use EMRs. All right, so let's close that. So growth hormone deficiency is the first endocrine disorder. There's also acquired hypothyroidism, Cushing's syndrome. Cushing's syndrome is rare, usually iatrogenic, caused by medications. But quite a quick word on growth hormone deficiency. So, and our growth hormone deficiency could be congenital, it could be acquired or idiopathic. Acquired hypothyroidism, you can have growth failure. So you can have, this can actually be the first sign of hypothyroidism is growth failure. Symptoms can be very subtle. Kids can tolerate a really, really high TSH without symptoms. In adults, TSH gets to 8 or 9 and they're complaining about a lot of tiredness and symptoms, but kids, you'll see them with walking around with a TSH of 80, 100, 150, and really the only thing is a little bit of slowing on the growth. You may see a delayed, a marked delay in the bone age. Cushing syndrome. Now, Cushing syndrome is not Cushing's disease. We're talking about Cushing syndrome here. Iatrogenic is the most common cause. Weight gain with decreased growth velocity is the key sort of finding when we are considering an endocrine cause of slow growth. Right, let me just see if there's something else here. Question from Dr. Mohammed. What is the incidence of growth retardation in juvenile diabetes? Great question. So growth retardation is chronic illness. So if we recall my previous slide, chronic illness can certainly present with growth retardation. So sometimes we do see patients who present who are presenting with type 1 diabetes. Typically, children often will present in diabetic ketoacidosis. They do have stunting of growth and significant weight loss that happened just prior to presentation. And they will have a big, rapid, what we call catch-up growth. From my first slide, if you recall, there can be a significant catch-up growth once insulin is on board and they have a pretty good, a big growth spurt. So yes, chronic illness would present with growth retardation. All right, so let's do, I think I was at Cushing syndrome. So yes, Cushing syndrome is iatrogenic, which is the most common cause. Typically, children who have severe asthma, a lot of times they are on high doses of steroids, autoimmune conditions that are on high doses of steroids. They may have growth retardation, and typically it's weight gain with decreased growth velocity. All right, so this is just a brief overview of some of the endocrine disorders that affect growth. Each of these, as we sort of briefly discussed, they could all be separate lectures, but just wanted to go over a few of them. So this is a chart that illustrates nicely. You have a 2 to 20 year growth chart, right? You've got the height chart and the weight chart here. An endocrine cause of poor growth would typically be where your weight is relatively well preserved, whereas the height velocity is severely slowed. So this is a typical pattern that we see in an endocrine cause of growth. Now, if it was a chronic illness or a GI, gastrointestinal cause or nourishment cause of poor growth, you would see wasting or poor weight gain associated with stunting of growth. So, but when you have weight that is relatively preserved with, and these children look heavy or overweight because of this, that is typically a concern for an endocrine cause of growth issues such as growth hormone deficiency or Cushing's or hypothyroidism, as we discussed. Right, moving on. Okay, so now we've kind of, just to summarize what we've talked about so far, we've kind of gone over normal growth patterns, what data points we need to have in order to evaluate a child for growth. How do we consider that it is pathologic versus just a normal variant like familial short stature, etc. Moving on, now we've got a child we are actually evaluating for growth. So when you see a child and there is a concern for growth, either say there was true short stature or poor height velocity or one of those criteria that we talked about, first thing, of course, is a good history. Won't go into that in the interest of time. A good thorough history. Family history is very important, especially for constitutional delay of growth in puberty, strong family history of thyroid disease, things like that. Now, on the physical exam, of course, we look for any obvious dysmorphic features. You look at the nutritional status. This is key because if the nutritional status is poor, we may not be looking at an endocrine cause of growth deficiency, or growth failure. It may be a nutritional cause of growth failure, right? We have to address the nutrition first. The thyroid gland exam, of course, a neurological exam, pubertal status, very important because that gives us a clue, especially with constitutional delay of growth in puberty, depending on the age of the child. Weight-height relationship, I've highlighted that because that really gives us such a useful clue as far as endocrine causes, right? The weight is relatively preserved and linear height is what falls off. And body proportion. So if you have significant disproportion, the differential changes with that as well. Okay, so initial workup in the evaluation. Again, I've tried to keep this brief, just typical studies that we would get when we're evaluating a child. If we're truly concerned that there may be a pathology, right? If we're not concerned that if it's not familial short stature, and if it is not constitutional delay or late bloomer, then we consider, okay, this may be a pathology, we need to start the workup, right? So what we would initially get is typically a thyroid panel, total of free T4 and a TSH. We need to get a comprehensive metabolic panel to ensure there's no chronic illness that's being missed, a complete blood count, sedimentation rate or CRP, IGF-1, IGF binding protein 3. These are growth factors. We always will screen for celiac disease with the tissue transglutaminase, IgA. The reason we do that is because sometimes in early, we have had patients where celiac disease is not always associated with weight loss initially. It may just be sort of insidious and present with growth failure. And this is another point I'd like to highlight. If a female child has features of Turner syndrome, we would consider chromosome analysis. I would actually say if even short stature in a female, we would typically send a karyotype. We would always rule out Turner syndrome in that case. Okay. And then radiological studies, we would do a bone age X-ray. We talked about the bone age X-ray and how it helps us. So that's a typical sort of initial workup when we are considering a pathology in a child with short stature. I like to highlight short stature as a symptom, right? Not a disease. So we're just working up to see if there is a pathology ongoing. All right, so we are at sort of the last bit of the talk. So I'd like to actually, present a case. I like to do this with all the talks because I'm a clinical person. This helps me think through a topic best. So this is a patient of mine. I saw him about a year and a half ago. This is a 5-year-old boy who presented because the pediatrician was concerned about a growth issue. Parents also said there was a little bit of tiredness. He just doesn't seem as robust as his friends. And this is his growth chart. Okay, I'll let you take a minute to look at it. A few points on here. So this is a boy's chart, right? Boy's growth chart, stature for age. This is where he was initially, right? He was along I don't know how well you can see on the screen, but he was initially along the 25th percentile. Seems to be sort of drifting down, right? And now when I see him, I'm not showing you this because I'll show you that, in the future slide to show you how things went. But when I saw him, he was down here on the growth chart. Okay, so this is your child. The pediatrician has sent this patient to you to evaluate for growth. So first questions, we'll work through all the points that we discussed earlier. Is the child short? Yes, it's about 2.1st percentile. When I first saw him, may not be very clear to see on the chart, but it was about the 2.1st percentile. So anything less than the 2.3rd percentile, we would consider short stature. So he is short, right? Not all short stature is pathologic, but he's short. That's all we know at the moment. Next question is the height velocity impaired, right? Yes, he is growing at less than 5 centimeters a year. Let me go back to that chart. If you measure his height velocity, it's actually declined. Okay, so he does have an impaired height velocity of less than 5 centimeters a year. The next question is, what is the mid-parental height, right? If you recall reasons for concern, if the height of the child is very different from the family pattern, that is the reason for evaluation. So what is the mid-parental height? His mid-parental height is the 95th, and he is at the 2.1st percentile. Kids should be picking a growth curve and sticking to it right from age 3, right? So there's a big discrepancy, family height and his what is the predicted adult height. Now we need a bone age to predict height, but based on the current growth curve, he looks like he's headed towards the 2nd percentile, right? And his target height is the 95th percentile. So so this is his growth chart again, right? He's got some decline in velocity, he's short, and he's significantly shorter compared to his family. So what are the next steps? So we can kind of work through the points again. We talked about an evaluation. He didn't have any physical exam findings. Again, in the interest of time, I'll summarize what I saw in clinic. He didn't have any physical exam findings that were specifically concerning, but we did an initial workup, which showed a TSH that was low, it was 0.02, a free T4 that was also low at 0.6, a comprehensive metabolic panel was done that was normal. He had a low normal IGF-1 level. And this just puts, I've just put in the reference ranges, so you know when I say low, this is what the range is. Underwent a growth hormone stimulation test because there was a concern. There was a low normal IGF-1 level. He did have findings that were concerning for an endocrine cause, right? He already had one hormone deficiency of a low TSH and a low free T4. So we had him do a growth hormone stimulation test. His peak growth hormone level was 1.3. This, just in the interest of time again, I'll briefly go over growth hormone stimulation tests, and I'd be interested to know what we're using at your center for growth hormone stimulation testing. The peak level was 1.3. We expect normal growth hormone levels to peak at about greater than 10. So less than 10 is considered growth hormone deficiency. His was 1.3, so he had growth hormone deficiency. When we do our stimulation tests, we also check a cortisol level. It's a good opportunity to check it, so we use it. His level was suboptimal with a peak of 11. And we want to see at least 16 to 18 on a stimulated cortisol level. We did an MRI pituitary, which is the next step. When we have a child with confirmed growth hormone deficiency, we do want to look at the pituitary gland. We order an MRI with and without contrast in order to see if there is any pathology in the brain that could be leading to growth hormone deficiency. All right, so this is our initial workup for him and what happened after that. So, MRI pituitary showed diminutive appearance of the pituitary gland and the pituitary stalk. He did not have a normally located posterior pituitary bright spot. There wasn't evidence of ectopic posterior pituitary neurohypophysis, which is located along the base of the hypothalamus or median eminence. I'm just reading the report that I received from his MRI. And this is actually just an example picture of an ectopic posterior pituitary. It is a finding that we see in some children who have growth hormone deficiency. Okay, so we have this 5-year-old boy with panhypopituitarism, essentially, right? Growth panhypopit is when you have 2 or more deficiencies, pituitary hormone deficiencies. You have growth hormone deficiency, hypothyroidism, central hypothyroidism, as the TSH was also low, and adrenal insufficiency. So what did we do? We started him on replacement therapy with recombinant growth hormone, levothyroxine, and hydrocortisone. Right. So this is his growth chart after we initiated growth hormone therapy. He's had a fairly good response. Once he had hydrocortisone and levothyroxine on board, his energy levels have been great. Mom is very happy. He's doing well, so he's on treatment right now. So that was a case of growth hormone deficiency with an ectopic posterior pituitary gland. All right, so growth hormone therapy, again, this is another talk by itself, of course, growth hormone therapy and its causes and approach to evaluation, but it is typically given as daily subcutaneous injections. This is the Norditropin FlexPro pen. You know, a lot of children will do it themselves. The injections, they dial up the dose, give it to themselves every night, or the parent does it. There is a newer formulation now with once weekly dosing called Skytrofa, but typically most patients are on the daily subcutaneous injections of growth hormone. All right, so that is coming to the very last bit of my talk. So I always use messy in my talks because he was on growth hormone therapy as a child, and he's 5'7" in stature. So again, a point to be made is growth hormone therapy does not make you grow taller than your genetic potential. It just allows you to attain your genetic potential or target height. And this year I could add this picture in my lecture, so I'm happy to do that. Yeah, so in summary, the pattern of growth is far more valuable than a single height measurement in assessing the health of a child. We want to remember that short stature is just a symptom and not a disease. History and physical are a key points to evaluation. Weight for height is very important when assessing variations of growth because the growth pattern, weight versus height, gives us clues for endocrine causes versus a nutritional cause. And etiology of growth failure may be either, well, not growth failure, rather. Etiology of short stature may be just a normal variant, or it could be a pathology. Right, so last picture for the day would be, these are two players at the Bullets. Then they were called the Bullets, Manute Ball and Muggsy Bogues. They are not pathologic causes of tall stature or short stature, but they were both on the same team. So it was a fun picture. And that's all I have.
Yeah. Thank you. Thank you very much, Shabana. Am I audible?
Yes, can hear you. Yeah.
Yeah. Thank you for really bringing it out so clearly how the causes of short stature can be deciphered from the problem. I often get challenged right from my relatives and my home about children being very tall and the parents are not really that tall, and they ask, where does this height come from? And
Yeah.
it's beyond the standard deviations, right? These children
Yes.
are tall. Is it from their uncles, their aunt? Where did they get that? They don't seem to have a clear explanation. So how do we
Yeah.
explain it as endocrinologists that this mid-parental height theory is actually not so wrong? How do you convince them?
Yeah, we tell them, well, the first thing is, of course, tell them that it's just an estimate. The other thing is when there's a big discrepancy between mom and dad, that whole calculation goes out the window. You can't really rely on that. So sometimes you see that in families where there's a big discrepancy between mother and father's height. But as you said, patients don't always read the textbook. We have patients who are beyond that 2 standard deviations, very tall children. They probably got a gene from, that from grandpa, or sometimes I have seen situations where I suspect that mom or dad had an undiagnosed growth hormone deficiency that the child did not inherit, and so he had a true stature.
Sure.
That is possible. We do evaluate some children where the parents are short, and then the target height would look appropriate for the child. But if the dad is short compared to his family, then you want to consider, okay, maybe dad had a missed growth hormone deficiency that we want to consider for the child.
Yeah, thank you. Are there any questions from the audience? Would any of you like to ask any question? I don't see any in the chat box yet. Yes, Dr. Mohammed, would you like to unmute and ask the question, Dr. Mohammed? Dr. Mohammed, if you could kindly unmute or put it on the chat box, either way is fine.
Yeah. Trying to see if my chat box is.
Dr. Marmin, if you could, I think he's unable to unmute. If you could kindly allow Dr. Mohammed to unmute, please. Yes, Dr. Mohammed, you can.
Yeah. Okay, can you hear Shabana?
Yes, yes.
Yeah, it was a nice speech. Nice to hear all. And what I'm asking is there any relation between the physiology and the growth retardation? In the stature and physiology, is there any interlinked relationship?
Stature is genetically determined. Of course, physiology in the sense that there is
the routine physiological aspects, will it be affected by the stature?
Oh, good question. No, typically not, unless it's a pathologic causes of stature. So, of course, if there's short stature, I think what you're asking is that if there's short stature, is there any downside physiologically?
Correct. Yeah.
Really, there is none that's known. It's, of course, weight management becomes a little more challenging if stature is shorter. So people have to be a little, watch diet and nutrition closer, because it will be sort of a lifestyle related complication that comes with that. But
Yeah, that's
otherwise,
good.
not.
Yeah, lifestyle diseases and the stature has nothing in common relationship. No.
Unknown. If it's a non-pathologic cause of short stature, no, there should not be, at least.
Thank you.
So I have a question for the endocrinologists. Actually, I'm just curious. What do you use currently for growth hormone stimulation testing, or I'm just curious to know what the practice is for growth hormone evaluation, or are there patients who take it, or?
So I am an adult endocrinologist. I don't see very many children with growth hormone deficiency, but the ones we do, do need to do a stimulation test. We do a combination of the anthropometric measurements, plus we do a clonidine stimulation, even though it's not the most sensitive one. But we do insulin hypoglycemia test. We do use very occasionally, very carefully. We do that. We don't have the arginine stimulation and the other glucagon stimulation very freely available. So it's usually clonidine plus the other measures, the height, velocity.
Okay, and then of course, a growth hormone therapy would be out of pocket, I guess, right, cost-wise for the patients.
Yes, it's out of pocket for most of our patients. That's true.
For the patients, because that's here. Of course, it's insurance dependent, so we have to, and it's the cost is prohibitive for families unless insurance pays for it. So it's always run through insurance. That's why we do all this testing honestly, it's to submit data to the insurance companies to get approval for treatment.
Yeah.
Are there which atlases do you use for skeletal or bone age studies currently?
We use the Grulich pile. Yeah.
Grulich pile. I was just asking because it's, as you know, it's a Caucasian collection. Sure. Even in the US, we have a mixed demographic. It's not all Caucasian, but that's all we have. So I was wondering if there were any other practices. Yeah. And observation on stature. What is your observation on stature with the use of topical steroids for eczema and inhaled steroids for asthma? Right. This is a concern sometimes families will have as well. Have not seen a situation where there is growth retardation with topical steroids, even in children with, who have been on, ointments for years, as far, even 7-8 years, have not seen growth retardation. Inhaled steroids, there has been some concern for actually adrenal insufficiency, despite being an inhaled mode of delivery, but have not seen inhaled steroids causing growth retardation, except the children who have, concomitant, frequent, little courses of prednisone. They take, every month or so they have an exacerbation and they do a 5-6 day course of prednisone. Then yes, there's some weight gain and slowing of growth, but just topical steroids and just inhaled steroids have not seen. If they're using it correctly, I haven't seen retardation that's worthy of, stopping therapy or evaluation. I'm not sure. Have you seen a lot of that in at your institution? Inhaled steroids causing retardation? Dr. Elizabeth?
Dr. Elizabeth, if you can kindly unmute Dr. Elizabeth.
And are you able to use growth charts as well in the EMR, or are we still using plots, or how does, just curious of that. Various institutions, I'm interested to know.
Dr. Marman, if you could kindly permit Dr. Elizabeth to be unmuted. I think if you can allow everybody to be unmuted, it's easy to talk.
Oh, right. So it's...
Yes, Dr. Elizabeth, you're on.
Yeah, that's fine. That was a very nice talk, very simply put out, very clear. What we have in our country is we have a moving population, and the population finds it difficult to do a growth chart on their own. They expect the medical healthcare providers to do it for them.
Right.
So that is our biggest block. So now I try to tell them it's just a graph, you do it try to get the height and the weight plotted
Mhm.
at a 6 months basis, or get it from their school health records.
Right.
But again, the long-term observation we don't have, because we
Yeah.
don't follow up a child linear fashion, no? We only
Right.
get them
They're
at the
moving.
cross section. Yeah, so that is our
Okay.
problem. So
Yeah. So
since you
growth,
said you have an EMR already, I thought it would be much easier if you can follow them.
yes, it is, and especially even outside data points, they import that into it. You know, patients who have moved, they can actually pull data from outside institutions into that EMR. So it is much easier with that. Yeah.
So I think we are trying to get in the software into our system, which will be the only solution.
Right, and this would be more patients entering data
Yeah.
to some extent.
Because when
Yeah.
you triage them, we do take their weight and their height. If it
Yeah.
goes automatically into a software where it is put into the patient's file, then it
Yeah.
is easy.
Right. Yes. Yeah. Is there a lot? Do you see a lot of constitutional delay consults, and do have patients concerned with that as much there? Here, it's a huge number of patients, so
No,
not as much.
no.
Yeah,
In-
it's
in
more of
the-
a psychosocial. Sorry.
No, in the endocrine OP, I do see maybe 1 or 2 a month.
Yeah.
CGDPs.
Okay. Yeah, because yeah, here it is. Of course, it's a huge concern. And mostly psychosocial. We do a small course of testosterone sometimes if they haven't shown signs of puberty by age 14, but I suspected it wasn't as much outside here.
So the bone age is a very useful test we do whenever we have short stature child in the pubertal age group. And so
Yeah.
how much difference will you permit between the bone age and the chronological age if you're suspecting CGDP? Would it be 1 year, 2 years? What is your
I would
cutoff?
say more than a year, because one is still considered normal. Now the bone age, of course, is subjective. Sometimes I read it with the radiologist or read it myself. But typically in a classic CDGP, I would expect at least 2. At least that's what I usually see. The ones that are pretty, but 10% of CDGP, as you know, do not have a delayed bone age, so they would be 1 year delayed. I've noticed that when I repeat their bone age a year later, there is still that gap. So that's more reassuring for the family. Sometimes it doesn't look great when they're looking at the predicted height, but I just tell them to have patience. They're clinically not in puberty yet, just reassess the bone age in a year, and it hasn't moved much. So that is, that's patients don't read the textbook again. No, that's
Yeah.
Yeah.
Are there any other questions from the audience? Would anybody like to ask any question? One of the questions which people commonly ask is what proportion of the contribution to the height is the genetic potential and what proportion is the nutrition and the other factors? So would 80-20 be a good mix, you think? Would that be, or what would you usually tell your patients? 80%
I'd say
is the
even
genetic
more
potential.
genetic. I put
Yeah.
more weightage on genetics just based on what I've seen and what all the studies, really at the end of the day, unless there was a real nutritional deficit, I don't think it has that much of an influence. Of course, overnutrition can also cause some advancement in the bone age.
Yeah.
There is some degree of that. I don't think it's quantified as yet. And it's probably hard to quantify as well, right? Because how
Right.
much of bone age advancement, how do you quantify degree of bone age advancement? But I think I would lean towards more than 80
Sure.
genetic. Yeah.
Okay. All right, Dr. Elizabeth, can we close? Is there any other questions?
Yeah,
Dr. Elizabeth?
I think so. Okay.
Yeah.
All right. Yeah, I'm happy to answer offline or chat offline anytime.
Yeah.
Thank you very much for that interesting session.
Okay. We're
Yeah.
happy to do it.
Yeah.
Thank you. Nice meeting you all again.
Yeah, thank you very much, Shabana. And I want to thank all the participants who came for this CME webinar and to announce that we will be having these webinars very regularly, and kindly feel free to join in the weekly webinars which we have. Thank you once again and have a good evening. And thank you so much, Shabana, for being part of this webinar.
Oh,
We're grateful
my
to you.
pleasure.
Thank
Happy
you.
New Year.
Bye.
Okay, thank
Bye.
you.
Have a
Yeah,
nice day.
bye. Bye.